Okay, so this is chapter 21, and this is the sensory system. So let's rock and roll and get started. So, sensory perceptions. The sensory system includes seeing, hearing, tasting, smelling, touching. Okay, those are the senses. Also, equilibrium, knowing whether or not your body's moving, sensing your posture and position in space. That's equilibrium. And your inner ear controls that. So your sensory system is actually, it provides a lot of protection for, for your body, can warn you of things, and also is a mechanism for experiencing the world, right? So the structure and function. So you have to have receptors in the eyes, in the nose, in the tongue, in the ears that receive a stimulus, and then a route for the nerve to carry that stimulus to the brain, and then a center in the brain that interprets whatever that stimulus is. So in other words, my eyes don't really see. My eyes receive the sight, send it to the brain. My brain is what really interprets it and says, oh, I see London, I see France, or whatever, right? So the functions of the sensory system, your visual for images, hearing for sound, proprioceptors, right? And the inner ear maintain your balance, your equilibrium. Chemoreceptors, like chemical receptors in your mouth, are for taste. There's also chemoreceptors in your nose for odors, touch receptors to sense the surrounding world. And then your internal organs also have nociceptors, which we'll talk about, that can sense pain and pressure, that type of thing. But all of these are just receptors to send signals to the brain for your brain to interpret whatever the information is. Okay? So chemoreceptors are for smells and tastes. Make sure you understand that. Mechanoreceptors are for pressure and vibration. Thermoreceptors, temperature. Nociceptors are pain. Photoreceptors for vision. Proprioceptors are about your equilibrium, right? And your orientation of the body, and they're in your muscles and joints. Okay. So general sense organs, they're all over the place. They can detect pain, touch, temperature, pressure, itching, that kind of thing, and your position in the world. Okay, we already talked about that. Tactile or touch receptors, well, they're found in the skin. So the word tactile means touch. Know that. No, tactile means touch. The greatest number of touch receptors are in certain areas of the body, specifically the fingertips, the back of the neck, the soles of the feet, and around your lips. Most of those receptors are to sense pain, okay? But the parietal lobe of the brain is what interprets that tactile stimuli, okay? So when we talk about pain, nociceptors are nerve endings that carry impulses to the brain. And these receptors are all over the place. They're in every organ of your body, not the brain. None in the brain. Your brain can't feel pain. But the receptors are everywhere else, okay? And they use what are called fast and slow pain fibers, okay? Fast fibers are usually in the skin, mucous membranes, and they can identify localized pains. Slow fibers are deep. They're visceral, which means deep. Deep in your organs, they produce like an aching, like a gut-wrenching deep pain. And remember, no pain in the brain. And I know that somebody's probably saying, well, what about headaches? It's not pain in the brain. It's usually something else. It's a muscle ache from the base of the neck. It's a sinus headache. But the brain itself has no nociceptors and cannot feel pain. Okay? So let's talk about the pain pathway. In other words, when something happens to us, how do we feel pain? Okay. So we cut our finger, and that tissue releases these chemicals that stimulate the nociceptors, and that triggers the pain. So a nerve cell, a neuron, sends that signal up to the spinothalamic tract, up to the thalamus in the brain. And then once it gets there, the spinoreticular tract that carries the signals to the reticular formation of the brainstem then relays that signal to an area of the brain called the postcentral gyrus, and that's in the cerebrum. And that's where the brain goes, ouch, that hurt. You're aware of the pain. And then the impulse from that spinoreticular tract bypasses the thalamus and travels to the hypothalamus and the limbic system. And these areas trigger different responses to pain. So the limbic system is all about like behavioral and emotional things. So if you are scared, you might feel nauseous, right? I'm sorry, if you're in pain, you might feel nauseous. If you're in pain, you might feel afraid. That's because of that one last action, that one last tract that those neurons take where they trigger the hypothalamus and the limbic system. That's why sometimes when people are in a lot of pain, they'll vomit or they'll be terrified. Okay, that makes sense, right? And then there's something called referred pain. Referred pain, think about a heart attack, an MI. Somebody has a heart attack and they don't necessarily have chest pain, but their left arm hurts. That's referred pain. Make sure you understand this, okay? So in other words, there are sensory fibers from an organ. Let's say it's the heart, okay? And then there are those that are on your skin. Well, when they travel up to the brain, at some point they converge, they meet like two forks in a road into a single pathway. And the impulses from both from the organ and from the skin kind of meet. And as a result, the brain kind of gets it a little screwed up. It misidentifies where the pain is coming from. Was that pain coming from my chest or was it coming from my arm? So that's why oftentimes people will have referred pain. Isn't that amazing how the body works? All right. So your senses, we already talked about what they are. Let's talk about specifics. The eye, it's how we see. Medical term, ophthalmo, that is your prefix for the eye. Ophthalmology is the study of the eye and vision. Know those words, okay? Your eye has more than 65% of your body's total sensory receptors. You don't need to know that, but it's a fun fact. You can see 2.7 million different colors. You can see a candle flicker from 14 miles away. Did you know that? It's amazing, okay? Here is a picture of the eye. So some of the things that you do need to know, all right? You need to know the lacrimal or nasolacrimal duct or the lacrimal sac right here in the corner of the eye. And that's going to be important when you're administering eye drops to people. When we get to med surg and pharm, it's going to make sense, trust me. So know that that is the lacrimal sac or the lacrimal duct, okay? The iris is the colored part of your eye, okay? The pupil in the middle is that little black hole, and the pupil actually can contract and dilate depending on light. That is what controls the amount of light going into the eye is, okay? And then let's take a look at this picture. Okay, there's your lacrimal gland. That's what makes your tears. Okay, the white of your eye is the sclera. And you do need to know that. Here, let me highlight these for you. So the sclera, you need to know, the white of the eye. The pupil is the little black hole in the middle. The iris is the colored portion of it. Okay. And then we're going to move on to the next slide. And we're going to see even more portions of it, okay? The conjunctiva, okay? What is the conjunctiva? I'm going to show you on me, if I can. If you pull down the lower lid, this is the conjunctival sac, okay? And that gives you a lot of information about a patient, what color it is, if it's moist, if it's dry. So when you're looking at the eye, the conjunctiva actually covers this portion of the eye, but you don't really see all of it. All you see is the part that you can visualize when you pull down that center portion of the eye, okay? And then behind the pupil, behind the eye, this is the eyeball, this is the lens, okay? And then behind the lens, there is this space where you have your retina, okay? There's your sclera, and then there's the nerve, and that's the optic nerve that sends the signal of whatever you look at to the brain for your brain to go, oh, that's a house, or whatever you see, okay? So the sclera and the cornea. So the sclera is the white of the eye. The cornea is the lens of the eye, okay? The layer inside is mostly liquid, the aqueous humor. And then where the lens of the eye is inside is the vitreous humor. And neither one of them are funny. And don't worry about all of this specifics here. You don't need to know all of that. It's really not that critical. But so nerves that make your eye work. So remember, we talked about 12 cranial nerves. So cranial nerve 2 is the optic nerve. And that's the one that sends the signal to the brain to be interpreted. What are we looking at? Then you have the oculomotor nerve, which is number 3. That's the one that makes the pupil constrict when there's a lot of light and dilate when it's dark. It also can make you raise your eyelids, okay? Then your trochlear nerve, which is cranial nerve 4, voluntary eye movement. I look up, I look down, I look to the side, right? Your ophthalmic nerve is actually a branch of your trigeminal nerve, which is cranial nerve 5. And that has to do with pain and temperature. And the abducens nerve, which is cranial nerve 6, innervates the lateral rectus muscle. In other words, the ability for peripheral vision. And then your facial nerve, which is cranial nerve 7, allows you to go and do the hairy eyeball. Blink, blink, blink. Okay. So there are muscles that control the size of the pupil, whether it's dilated or contracted, right? The action of the lens. So you need cranial nerves 3, 4, and 6, because they all have to do with voluntary eye movement, how you want to move your eyes without moving your head to see things around you, okay? Now, the physiology of the eye, how well you see your vision depends on what you're looking at, how bright is it, what kind of contrast is there, and then the speed. We have binocular vision. You know how you look at binoculars? Binocular vision, which gives us depth perception. So if I'm in my car, I can look and say, oh, I have about 2 feet in front of me before I hit the curb, right? Because the fact that we have 2 eyes in binocular vision, right? Smooth pursuit movement. You don't need to know this, but these are fun facts. Let the eyes follow something moving. Okay. Vergence. That makes your eyes converge if you're looking at something really close, or diverge when you're looking at something far away. In other words, if I bring something close to my eyes will cross. That's convergence. Okay. And that's, by the way, how we check for accommodation. Let's see here. Where are we? So the retina sends the receptors in the retina, send the impulses to the optic nerve, which goes to the brain. And then the brain goes, oh, I know what we're looking at. Okay. Your field of vision is what can you see when your eyes are fixed in one position? If you're just looking straight ahead, how much can you see around it? That's your peripheral vision. And what are visual concerns? Know these words. Presbyopia is age-related farsightedness. In other words, as we age, we need reading glasses. We lose the ability to see very well for things that are close to us. So if I can't see things close up, that means I'm farsighted. So presbyopia is age-related farsightedness. Myopia is nearsightedness. So in other words, I can see things close up, but I can't see things far away. Hyperopia is farsightedness for people that aren't old. And astigmatism, lens and cornea curvature irregularities that cause the vision to be blurry, okay, which it's actually more common than you would think. So there's a couple pictures here that show accommodation, how the light goes in and how the eyes will converge. There's myopia, and you can see that the dotted line is where the light is supposed to go. But you see how it's falling short. The solid line is not going all the way to the retina, so they can't really see well. And then hyperopia, same difference. And then presbyopia, okay? So just know those terms, okay? Is this statement true or false? Cranial nerves 2, 3, and 5 assist with eye movement. If you said false, you were paying attention. It's 3, 4, and 6. 3, 4, and 6. They're voluntary eye movements, okay? And cranial nerve 2 is the optic nerve. That's the one that sends the signal to the brain. You're not going to get tested on that, okay? All right, on to the ear. That's how we hear, and it maintains our equilibrium or our balance. Medical term for ear is oto, okay? You have 3 parts to your ear. The external ear, which is called the pinna or the auricle, and then the middle ear and the inner ear. And your ear can distinguish over 300,000 sounds. Otology is the study of disorders of the ear. Okay. Let's look at the ear. Pretty groovy. you have little teeny tiny itty bitty little bones in your ear too. So let's talk about that. So here is your external ear, the auricle or the pinna, okay? And then you have the auditory canal, which is this. And then you have this, which is your eardrum, also called the tympanic membrane. Make sure you know that. And that's in your middle ear, tympanic membrane. After the tympanic membrane, you have these itty bitty little bones. You have the malleus, the incus, and the stapes. You don't need to know that, but I'm just telling you for fun. Then in your inner ear, you have semicircular canals and eustachian tubes. These are fluid-filled tubes that help maintain your balance, okay? And over here, you have your cranial nerve number 8. And there's a cochlear portion and a vestibular portion, and they have to do with balance. And I want you to pay attention and say, look at this, that part of the ear drains into the pharynx, right? So your ear, your eyes, your nose, mouth, throat, it's all interconnected, right? So if you have a stuffy nose, sometimes you can't hear out of one ear, right? Vice versa. You feel like your ear's congested. Okay. So it's important to know this. The angle of the ear canal is different in a child versus an adult. With an adult, if you want to listen or look inside the ear, you want to pull the ear up and back. And with a child, down and back. Okay? Know that. No ceruminous glands, which secrete cerumen. That's just earwax. And then the eardrum is the tympanic membrane. Please know that. Okay? So I talked about the middle ear and that kind of thing. We got through that. Let's go to the inner ear. We talked about the inner ear with the labyrinths and the tubes and the fluid. When someone has a problem with balance, they can be diagnosed with something called vertigo. And vertigo can be associated with vestibular dysfunction, the vestibule, right? Because that's the part of the inner ear that tells your brain, hey, we're sitting up. Hey, we're lying down. Hey, we're on a roller coaster. Throw up. Okay. And then you have nerves, again, cranial nerves. The cranial nerve number 8 is your acoustic or auditory nerve. And that's the one that sends the signal to the brain. What are you hearing? What are you hearing? Oh, that's Van Halen, or that's Olivia Rodrigo, or it's Cardi B. Um, Here's the question. Is the following statement true or false? As sound waves enter the external auditory canal, they first cause the tympanic membrane to vibrate, which causes the incus, then the malleus, then the stapes to vibrate and send impulses to the inner ear. We really didn't go over that, and I must have switched up. Here we go. The answer is false. Let me put that slide where it belongs. So the sound waves go into the auditory canal and it goes to the tympanic membrane, the malleus, the incus, the stapes, and the inner ear via the oval window. But you don't need to know that. Okay, so don't sweat it. So here's another view of the internal ear, right? To kind of give you an idea of what goes on. But here's what you really need to know. Here are some things that can go wrong with hearing. No ototoxicity. Ototoxicity. Oto meaning ear, toxicity, right? Damaged, poisoned. So ototoxicity usually occurs due to certain drugs. Aminoglycosides, which are a type of antibiotic, loop diuretics, aspirin, those medications can be ototoxic. Okay, so make sure you understand what ototoxicity is. Vestibular dysfunction, vertigo, dizziness, tinnitus. That means ringing or buzzing in the ears. And that can be a sign of ototoxicity, but it can also be idiopathic. Idiopathic meaning we don't know why you got it. Might be nothing. Okay, so no tinnitus. And when people have hearing loss, it can be temporary, it can be permanent, depending on what happened. Noise trauma, I will add this because it is important. So if you listen to really loud music or you're in a band, so you're loud sounds all the time, it can actually damage your hearing permanently. Okay, so your mom was right. Don't listen to that heavy metal. And there's a word called presbycusis, which is age-related hearing loss. As folks get older, they tend to lose hearing, but specifically higher pitched sounds are the first to go. So if you're a cutesy little girl with a real high pitched voice and you're talking to an older person, they may not hear you. So it's more because of the pitch of your voice than it is how loud you are. So I have a deeper voice, and people rarely tell me they can't hear me. Quite the opposite. So typically older folks, presbycusis, which is that age-related hearing loss, and it's usually high-pitched sounds. So if you're talking to an older person, try to lower your voice, speak slowly. I mean, don't be condescending, but you get the idea. Okay. Balance and equilibrium, we talked about that. So the fluid that's in those tubes in the inner ear, the motion there confuses the system and can cause vertigo, which is dizziness, and then tinnitus. Meniere's disease, which we'll talk about when we get to med-surg, is a classic issue for people that have these symptoms, okay? Is the following statement true or false? Myopia is a condition in which the eye cannot bring horizontal and vertical lines into focus at the same time. False. Don't worry about this. No one's going to ask you about this unless you're going into ophthalmology, okay, which I don't think you are. Okay. Which of these symptoms is indicative of tinnitus? Give you a second to take a look at the answers. And please tell me that you said ringing in the ears. Ringing or buzzing, some kind of a in the ear when there's no sound is tinnitus. Taste, okay. The tongue, there's a cool picture of the tongue. This is the whole tongue, right? You can see lingual tonsils in here, okay? You can see taste buds underneath the skin or underneath the layer of the top layer of the tongue. And there's that dreaded epiglottis. The epiglottis is like a little trap door at the very back of the throat that when you put your chin to your chest, the epiglottis closes, which doesn't allow anything into your lungs. So when you swallow, it goes into your stomach. Tuck your chin. What you swallow is going in your stomach, not your lungs. All because of our friend, the epiglottis. Okay. And some more pictures of taste buds, blah, blah, blah. Words. Gustation. Gustation means taste, the sense of taste. It's what allows you to go, oh, that's sweet, that's salty, that's bitter, metallic, it's fatty, it's meaty, whatever. Make sure you know gustation. And glosso is the medical terms pertaining to the tongue. So if I said, oh, that patient has glossitis, you would be able to identify that they have an inflammation or infection of the tongue. Okay? All right, very good. And it says here smoking can damage taste buds, but not for me, maybe other people. Okay. And then your sense of smell. It's important. Olfactory. That is the nerve, cranial nerve 1. That is the sense of smell. Okay. Odors are just molecules in the air, and they can be individual or they can be groups of them mixed together. And those molecules go into the nasal cavity. Okay. And they go up, 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 up. And that cranial nerve 1 takes those smells, sends them to the brain, and the brain interprets, oh, that's feces, or oh, that's Susie Q's perfume, or whatever. Okay. Women generally have a more sensitive sense of smell than men do. Nose blind is a thing. The receptors get tired after exposure after exposure after exposure. I mean, I honestly don't know that I can smell poop anymore. It really has to be something bad for me to smell it after 35 years of smelling it. But that is a thing. And it's not in here, and I'm going to add it right here. Let's see if I can do this. I want to go to, let's get rid of this. I want to tell you that the medical term for the nose is rhino, right? Like a rhinoceros, rhino. So if you had rhinoplasty, you had a nose job. All right, so I'm going to add that there. Let's see. No, I don't want to do that. I'll add it at the end so I don't tie you up. There's a real nice kind of a flow chart that explains how you smell, okay? And then we already talked about, you can feel temperature, you can feel heat, cold. Pain is either superficial visceral, or not referral, referred. There's a typo. And referred. Superficial is topical kind of pain. Visceral's deep. And referred is when something else other than the injured part hurts. Okay? So make sure you know that, right? Superficial, visceral, and referred. And let's see, what happens when you get old? Well, we kind of already talked about it. For your vision, presbyopia, your depth perception decreases, peripheral vision decreases, pupil size can decrease, yada, yada, cataracts, right? Which looks like an opacity over the eye. It's the lens that gets hard, less tear formation, yada, 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 yada. Doesn't all have to happen, but it can. Hearing, presbycusis, we talked about that, right? Illnesses, injuries, more earwax building up, hearing loss, vertigo. Aging is a picnic for other people, not for me. Taste buds decrease. The number and function of them decrease. So you can't taste things the way you used to. Other people, not me. Smell can decrease. Tactile sensations can also decrease. Again, all the other older people, but not me. Not me. Is this true or false? A nurse needs to teach proper nutrition to clients with aging sensory systems. If you said true, you'd be right. Because what happens a lot is that older folks will start adding a whole lot more salt or sugar because they can't taste. And the next thing you know, hypertension, diabetes. So, and that's the end of this lecture. That wasn't so bad, was it? All right. I think the biggest part of the information were just remembering the structures and the words and pain. All right. It's been real. It's been fun. Have a good night. Bye.